Stones. Do you look after stones in general practice? Any interest in knowing anything about stones? Or do you want to ask me any stones questions?
When they come out of hospital, they have them on alpha blockers.
Yep.
What's that then?
Okay. So the idea is that alpha blockers, what's the prostate made of? The prostate is made of smooth muscle and gland. That smooth muscle carries on across the trigone at the base of the bladder and then up the lower part of the ureters, the bottom third. So it's all smooth muscle. The stone comes down and the smooth muscle tries to peristalse the stone out. But actually, because of the inflammation and all the rest of it, it just makes matters worse usually. So we put them on an alpha blocker to paralyse that smooth muscle. And for some mysterious reason, the stones have got a better rate of leaving the body. So we call it medical propulsive therapy, but it's quite the opposite. It's not propulsive at all. And it does work. It increases their stone-free rate. It doesn't work if they've got stones at the top.
That's 6 weeks, is it?
Until they've come with the stone in a little pot. Yeah. Any other questions about stones?
GPs organising sort of investigations versus sending to A&E?
I think if they've got acute renal colic and they're in absolute misery, I think you've got to give them some analgesia and send them up to A&E, and we've got to sort them out, haven't we, and assess them. I think if they've got that kind of grumbling, I've got some, you think they've probably got a stone, I think it's fair enough to send a referral and then organise. My favourite is really an IVU, to be honest.
Because I spoke to a radiologist the other day who said they would do the limited CT on
Yeah, I think for an acute patient that's what we do. Have you got access to stone profile CTs yet?
Well, only by sweet talking the radiologist at one time.
Should be soon. We'll talk about it in a second.
When you've got that, that's why I didn't mention it. When you've got that, I think if you think they've got a stone profile CT is the best, because it's got a lower dose than an IVU, and we'll know for sure whether they've got a stone or not. It's absolutely definitive.
Do they still do IVU?
We still do some IVUs, but the number decreases every year. But we don't do many. Even as an acute service, we don't do many. What about following up? This is a kind of pre-SIG thing. In the future, what about following up patients with stones yourselves? Would you be happy to get a KUB and the report comes back and says the stones look about the same as last year? Or would you rather we follow them up? Follow up a lot of stone patients at the hospital like that. Sorry?
Can we follow the...
Well, that's what I'm saying. So, if the report said stone burden's the same as last year, and you say to the patient, how are you doing? Any pain or symptoms? And they say no. Maybe worth exploring?
I think the answer to that is when we get the radiology report, it needs to be doubly interpreted.
Yes, yeah.
With a sort of a urological opinion saying this is the management for this particular stone. Yeah. And then I think I'd be happy. Okay. If I just get a report and I don't know how to interpret it, then I'll be horrendously writing query letters.
Yeah, okay, that's fine. Raj has taken a note by the sound of it.
What about looking for the cause of the stone?
Oh God, that's an almost futile task. Oh, sorry, I mustn't follow my arms. That's an almost futile task, unfortunately. They spent was it 5 million quid in Sheffield on a big study to look at causes of stones and dietary modifications to avoid stones. The answer was drink water. I could have told them that for about 4 million without any trouble at all. Even if you have recurrent stone formers, and you do their 24-hour urine and their blood biochemistry, we will find a cause for their stones in what percentage do you think? 1 in 100. So you can see large-scale testing of everybody is not worthwhile. The reason that we all form stones, if you go home tonight, this will be your second urological experiment of the day after making your own prostate. We in a jug, put a little bit in a cup, stick it on the windowsill, don't tell your partner, and come back after about 5 days, look in it, you'll see crystals in it. Your urine will make crystals. All of our urine makes crystals. Some people's urine forms crystals quicker than others because there are some proteins in there which inhibit crystal formation, Tam-Horsfall protein, and some people make more or less. So that's what it comes down to. If you make less of this inhibiting protein, you're going to make stones. So if you have one stone, you've got a 50-50 chance of making another one within 10 years. Yeah. So what I say to the patients, they will say to me, how much should I drink, doc? How much should I be drinking? Is it 2.5 litres like my wife says? The answer is have a wee. If it's pale yellow, you're drinking enough, and if it's orange, drink more. All right. There's no special magic amount, and that is the biggest way of them avoiding stones. If we follow patients up at the hospital with stones, if they're followed up twice annually, they will have less stones. It's called the clinic effect. We don't do anything, we just remind them of how miserable it was when they had a stone. All right? You can do that in primary care, I'm sure.